Webmaster Series 2020. It's a quick recap of pediatric nephrology, and we have already completed the successful 12 webinars, and we have entered to the third webinar on neonatal nephrology. Usually neonatal dialysis is less commonly covered, and it still seems to be a gray area for many of us. So today we have Dr. Rupesh Raina, who's the expert in the field, who's going to enlighten us on neonatal dialysis. And my sincere apologies, Dr. Sidarth is unable to join us because he's stuck up with an emergency.
Okay, so all set to go, Dr. Ganesan?
One second, sir. Dr. Rupesh Raina is an adult pediatric kidney disease hypertension nephrologist at Akron Children's Hospital and Akron General Medicine Center at Cleveland Clinic Foundation, US. He is also associate professor at NeoMed Medical University and Case Western Reserve University at Cleveland. He serves as a pediatric educational committee member for the International Society of Nephrology. He is a fellow of National Kidney Foundation and American Society of Nephrology. He also serves the National Kidney Foundation Advisory Board, and his academic interest is he's inclined towards transition of adolescent with chronic renal disease to adulthood care and renal replacement therapies in acute care renal failure, bone marrow transplantation, and inherited metabolic disease. His basic science research includes, but not limited to, identify non-invasive biomarkers, urine endothelium, and to predict ADPKD and disease progression. And so today we have Dr. Rupesh Raina, who's going to talk all on neonatal dialysis. Over to Dr. Rupesh.
Thank you, Dr. Ganesan, and good evening, everybody, people who are international. I'll say good evening to, good morning to everybody from US. I did not, so finally I could see my slides. So the structure of the talk is all about the neonatal kidney replacement therapy. Now the terminology is that changed. We don't want to use the term the renal replacement. New KDOKI initiative has made the changes to CRRT, which is coming up in 2021. So that's why CRRT is what renal replacement therapy advances and update. You guys know me very well. I've been there multiple times in India, and I do both adult and peds nephrology. I'm trained in both. So let's start with the AKI. Actually, the paradigm of the AKI has changed even the time when I was a fellow and graduating, and within like 7 to 8 years, the whole new entity of AKI has developed. And thanks to the Awaken, which I'm the steering committee member and also research committee, and we have done a retrospective consortium for the neonatal AKI. And a lot of things are upcoming and growing because of that. So the incidence of the AKI in neonate has been wide range between 8 to 24%, but unfortunately the mortality is also ranging between 10 to 61%. That's a wide range. It depends on the various factors about the birth weight and gestational age and what are the other comorbidities associated. Certain things are very important when you look into these patients who have neonatal AKI. What are the risk factors? One is a very young baby, which is less than 1,500 grams, perinatal asphyxia, near-term or term infant with low APGAR score, or treated with extracorporeal oxygenation, or requiring cardiac surgery. These are the things that has been more prone for the risk factors. And we have more papers coming around to kind of develop a risk stratification scores so that can predict the AKI in a neonate. This is a paper from the Awaken, which shows the incidence and outcome of neonatal acute kidney injury, which is a multi-central, multinational and observational cohort study. And you can see that this is a nice paper we did, which has shown the incidence, which has been divided on the basis of the gestational age. So if you have a baby which is less than 29 weeks, you have the incidence of AKI around 48%. If you have a baby between 29 and less than 36 weeks, it goes to 18%. But if you have anybody greater than 36 weeks, that goes to around 37%. Overall, the mortality is more higher in the younger kids because of other cofactors associated with the AKI. This is our paper. We have a neonatal AKI mortality, and this we have divided according to the spectrum of the neonatal AKI or neonates when you see them. If you have a very low birth weight baby, the incidence of the AKI is around 18, and mortality of AKI patients is around 55%. But if you go to extremely low birth weight baby, which we see in our institute, it's around 70%, and incidence is around 13. Sick near-term or term baby is around 22%, sepsis 70%, asphyxiated newborn. The AKI incidence is the highest, which is around 38%, which is more or less a pattern of any kind of AKI with ischemic ATN. And actually the ECMO, I don't know many centers in your place do ECMO or not. We do ECMO because of the complicated cardiac surgery that we do. And the incidence is AKI and mortality is pretty high, around 73%. Now, AKI in low birth weight babies is always an issue because they develop AKI earlier and they have a higher mortality rate. And some of the factors which is associated in the low birth weight babies are high mean airway pressures, low blood pressures, and the use of cefotaxime and definitely gentamicin. Those can be associated with the AKI. Now you have to be very careful with a very low birth weight baby, which is on ECMO. AKI incidence is pretty high, around 80%, and the mortality rate goes to around 3.2. So again, going back to the risk factors, these are the various systemic review we did. It's on the AKI neonatal and various studies, which shows you that it's a wide variety of the risk factors, going from low birth weight baby to APGAR, to use of antibiotic to go, and then infections, meningitis, shocks, asystole at the birth. It's a wide spectrum, and that was an issue that we came up to the point that this was so scattered, so not well defined, and that's why the reason that AWAKEN was established by David Ashkenazi and our group. Pathogenesis of the AKI, neovan AKI, because it's a little bit different than a pediatric or a young kid, because they're more susceptible to hypoperfusion. They have a low GFR, which increases over the time. They have a very high renal vascular resistance and high plasma renal activity. You have to be very careful with these patients because they have a very low intercortical perfusion, and we have seen that in our animal models. And definitely there is an immaturity of the tubules, there is an immaturity of the sodium-potassium chloride pump, there is an immaturity of the sodium chloride, there is an immaturity of the carbonic anhydrase proximal tubular enzyme. So the renal acidification, renal tubular defects is on the top, what you get with increased high renal vascular resistance and renin activity, which can potentiate any kind of hemodynamic perturbability. Now, this is a little bit of a busy slides, but you can just see what kind of mechanism of shock you can get in these newborns, and hemorrhagic, septic, PDA, and you can get a diastolic runoff, low diastolic blood pressure. Adrenocortical insufficiency, necrotizing enterocolitis is another issue where they get the abdominal compartment syndrome. It can cause a distributed shock, and it causes systemic inflammatory response, and definitely in cardiogenic, where you have the issues with the congenital heart disease, causes specifics, RBI nodilators, PG, if due to ductus-dependent cardiac anatomy. Now, as I have said before, that the concept of the AKI is just not AKI, it's a syndrome, because you have a ischemic insult with the hemodynamic changes with hypoperfusion and microthrombosis. On the other side, you have toxins, which are causing the exogenous heme proteins, antibiotic, contrast media, vasopressor. With that, there is an imbalance because you cause systemic inflammation both by the direct and indirect pathway, and you get into cytokines. And you get hypoxia, oxidative stress, you get endothelial injury that leads to apoptosis, necrosis, cell loss, or sublethal injury, which cause renal cell repair and regeneration. And that's why I always say that this is a syndrome. This is just not a single entity, what you defined as AKI. Definitely an antibiotic is a big issue in the children's, gentamicin and using amphotericin B. This is our article which shows the effect of amphotericin B. lipid complex in a very low birth weight baby. And this is how the whole concept of major apoptotic pathway in human ischemic model, you can see there's an activation of BAX, BCL2, P53, and FAS. You can see that extrinsic pathway require externation of the plasma membrane FAS receptor with signaling transaction via the FADD, which results in activation of the caspase. And caspase is going to be a very important, 3 and 8 both will be a very important target now for the AKI, and we are doing some of the studies in adults for the reperfusion of the AKI when they are going from the complete ATN to the recovery using the mesenchymal cells. And caspase 8 comes out to be a very important catalyst because that activates the apoptotic pathway. Now, difficulty to define an acute kidney injury in a neonatal period. It's birth, you know that it is not very clear that they have their own creatinine or the maternal creatinine. They regress at various age. Serum creatinine is definitely affected by medication conditions such as hyperbilirubinemia. Urine output also has a limitation as a criteria because it's not being very well defined. And many newborn, they develop actually a non-oliguric renal failure that may not progress to oliguric renal failure. And that's a problem as when they have a tubular immaturity, when they are having urine output, but that doesn't mean that urine output you have a complete excretion of solute. You still can have non-oliguric AKI, and what urine output or things that you have in the urine may not be representative of the complete osmotic load secretion. And that is a problem with the neonatologist when you talk with them to tell them, oh, this is mainly it's non-oliguric, but still this is the time that we have to act. This is how the various neonatal definitions is, which includes the urine output, serum creatine. Again, serum creatine, by the time it comes in, the damage has already happened. We wrote a very nice article in the press is about the pathogenesis of AKI in pediatric. What are the recent advances? Creatinine is the last one that you should be looking around because by the time you see creatinine, you have crossed the primordial prevention. And between creatinine and the recovery, you have only one thing. Either you go for dialysis, non-dialytic therapy, or mortality, being high or death. These are the 3 pathways you have to cross to reach to the recovery. So it's really sad to see that how during this time we don't have the correct definition of neonatal AKI. Stay tuned. Awaken is working, and we are trying to define the neonatal AKI in a different spectrum. Rather, we'll work on the scoring, and Dr. Wazir, Sidarth, Sethi, and other groups from Delhi, they have a neonatal AKI registry, which will be more predictable and which will be more clearly identifying the definition in your area, in India as such. So I'm looking forward for that data. I think the risk stratification score is so important because this entity is very different than any other entity if you look around. Now, this is a paper we did, comparison of different definitions of acute kidney injury in extremely low birth weight baby. And we have tried to use risk injury failure, the criteria from RIFLE, then we use pediatric RIFLE, and then we kind of compare different kind of criteria. And this is an extremely low birth weight baby. What we found out that from our study, overall incidence is lowest when P-rifle is used and highest when you use KDOKI, which is followed by Akin classification. So this is something you have to keep in mind, that if you're using pediatric RIFLE criteria, you can miss the AKI. And if you use Akin, it's around second number in the choice, and the first one, KDCO, was representing more earlier identification of the AKI. Now, while each definition offers its advantage, Akin would be a better definition to use as it predicts the possibility of hypertension in patients with AKI, and that we have found in our cohort. So this is for the extremely low birth weight baby, and I think it's very important for you to identify that kind of the criteria in an extremely low birth weight baby. Now, this is another Awaken study, and we found out increased incidence and mortality by absolute and percent change in the serum creatinine. And you can see when you have 0 to 50% greater than 50%, more than 100%, or more than 200 rise, the mortality goes higher and higher. And this is what the Awaken came up, and we have optimized the neonatal acute kidney injury definitions for the first week of life. And we did that with the mortality and finding from the multi-center trial, and you can see how the gestation age has been classified for that. We don't know the parameters, what we are looking on these neonates. There is no way you can assess the blood pressure and can augment and take that as into criteria that may be leading to 18. There is no way we can, it's so hard for us to define and make the diagnosis of hypertension, especially in a very low birth weight babies. And infant, this is our paper, and it's a challenge to identify. You can have a risk scores on the basis of the APGAR, on the basis of their antibiotic, on the basis of their respiratory status, but there is no objective parameters for you, as you can see in the pediatric population, to assess which patient will progress to ATN. This is my dream paper coming out in therapeutic apheresis. And I was actually joking with Dr. Bagga and Sidarth, and I said, you know, maybe this will be the important paper that I want to throw on the face of the adult nephrologist, which I deal so hard to tell them that the terminology of the kidney replacement has changed. It's kidney support, and same with pediatric. The old terminology says that you call the nephrologist when you are completing the need of replacement of acidosis, hyperkalemia, or fluid overload. Sorry, the renal, the need of the CRRT. Things are changing. You need to be very proactive, and just kidney replacement therapy is not needed for fluid and electrolyte or uremia or any other condition. You need it for a different etiology. You need renal support for nutritional support, volume control, manipulation of cytokines, solute modulation, cancer chemotherapy, respiratory acidosis, fluid management, and multi-organ dysfunction. So that kind of concept, and this paper will be out very soon, and I'll highly encourage you all to read. I have actually defined each and every indications with the systemic review, including both adults and peds, to say the concept has changed, and you should be more talking about the terminology for the kidney replacement therapy to kidney support, and that's what you see. The evidence in the children is very well proven. Sidarth, Sethi, and other groups. We have shown an excellent review article where we have shown fluid overload in critical ill children, and you can see the incidence of the AKI and mortality. This is a paper we have done in Awaken group. Higher plate fluid balance during the first postnatal week and a higher fluid balance on the post-day 7 were independently associated with the mortality at 7th day. Fluid balance on postnatal 7th day and negative fluid balance on postnatal day 7 were independently associated with the MB on the mortality on the postnatal day. So that's the concept I was trying to allude here. It's just not correcting the electrolyte. You have to move over and beyond and look into the renal support. And again, taking into account, it's another paper we published where we have shown the fluid overload and renal angina index, which is not very validated in pediatric neonatal population. Again, fluid overload, nutrition, and the cytokine manipulations and modification is what people are looking for. Now, what are the advances in the neonatal kidney replacement therapy? First advancement is not renal replacement, it's kidney replacement therapy. And technically what you do first is basically you try to modulate and stimulate the kidney functions for using less intervention as far as the kidney replacement or the renal replacement. You try to do that before you really push to the edge to do the kidney replacement therapy. Due to the size and administering CRRT to infant particularly is very challenging. There's a lot of challenges for placing catheter and obtaining vascular access because nothing is approved for FDA, and most of them is a challenge when you have a kid with less than 25 kilograms because there's no yet machine approved in US, but I'll come to the more in detail about the Carpe Diem Nidus, which is more in Europe, and now we have Equadex, which we're using, and our center is going to use it too. And currently available, any kind of KRT machines which are only approved for more than a patient more than 25 kilograms can disturb the homeostasis. Very hard to balance their electrolyte and homeostasis. Epidemiology, AKI has been found to be a growing problem in pediatric population, with almost 1/3 of all hospitalized children developing AKI. And about 5.8% of pediatric patients have required KRT and has been associated with worse outcome for infant with mortality rate of around 24%. And also the morbidity, which is reflected in the form of longer hospital stay in infants or in the KRT. This is a nice paper we have, the International Pediatric Dialysis Modality Survey published in PLOS. And there is a lot of variability. Like in developing country, people are pushing for more for PD because that's what they have. In developed countries, CRRT is kind of going into the spectrum more higher because, and some of the patients who have inborn error of metabolism, the choice was hemodialysis. But it was so nice to see about in neonatology, in developing country and also in developed country, people are more inclining towards the PD, which is a modality that's kind of going out of norm now. And I should say that this is an easy available modality for you, and nobody has proven the benefit, whether the PD is good or whether the hemo is good or whether the CRRT is good. Only proven benefits are when you have a patient with inborn error of metabolism. Yes, you have to get the ammonia a little bit go down more quickly. You can definitely use the hemodialysis and then step down approach, which I'm going to discuss with you guys. And CRRT definitely is needed for the patient with the intracranial pressures because of the less variability in their hemodynamics. But there's no evidence right now. And it is very hard to do randomized control trial or have a double-blind control trial to see patients reflect with what. So that's just my perception is, and that's been proven in our survey, in the International Pediatric Dialysis Survey. It's been all across Asia, Europe, and that's what the common consensus was, at least in the pediatric neonatal section. The problem is that these neonates or infants are not regular pediatric patients because they're very small. And sometimes when I go and see them, they're the size of my palm, and they're like very low birth weight baby. Very difficult to place and access because we do not have an appropriate size catheter. The unique and delicate physiology of neonate and infant, very hard because the tubules are not mature. You don't know how the minor changes to homeostasis can predict the change in the electrolyte. How are you going to balance the fluid because they have insensible loss, they do not have much subcutaneous tissue. It is a very unique and delicate physiology. And the most common roadblocks that I see is the fluid balance, large circuit volume, and difficulty in obtaining the recommended blood flow, which is around 40 ml per minute, because then it affects the clearance. This is a nice paper. I will highly recommend you to guys read about the renal replacement therapy in pediatric acute, and we talked about a lot on the modality of how to use the PD and hemo. And this is just to tell you like what is the difference between each modality. And I'm not going to go into detail, but just tell you that hemo is more diffusion, PD is diffusion, so using the peritoneal membrane. And there is a whole concept of the pore model, or the concept of using the pore on the basis of the diffusion, and then another whole large surface area. But when you talk about CBVH, whether it's H, D, or F, you're using the convention and diffusion. With filtration, you're also using the replacement therapy. And SLED has been used, and Sidarth has done a lot of work on SLED. And SLED is another mode of, SLED is another mode of therapy which includes diffusion, but again, in neonate, you have to be careful with the amount of blood flow and how they're going to react with the big membrane. So just to give you in perspective how each therapy work. Going to PD, it's the touted immediate advantage of PD over the other form of RRTs. It's simplicity of operation, it's preservation of the vascular access, and ability to perform dialysis in children, which is with hemodynamic instability. But The more remote advantage of PD in children who may require long-term dialysis are decreased dietary restriction, the ability to perform dialysis at home, and possible improved preservation, which is a long-term outcome in children. But again, the problem is the catheter, and their intraperitoneal length may be too long for use in the small infant. But I'm preaching the choir because you guys do PD more than me in children. And the way to just start the PD prescription is to delay the initiation of PD with dialysis-free period of 2 to 3 weeks after catheter insertion is advisable when and possible. And once PD is started, low initial volumes like 10 ml per kilogram or 20 ml per meter square and short dwell time of 30 to 50 minutes. Then you can increase the first week to fill volume of 30 ml per kilogram or 800 ml per meter squared, and then you can subsequently go slow, and that's something else. This is another various kind of PD therapies you have. You have continuous PD with, you have high volume PD, you have tidal PD, you have continuous low PD. Again, just showed you the benefit and limitations about those use. This is actually, this was a perfect time. Dr. Ganesan asked me to give this talk. We just submitted a very nice review in the ACKD and AJKD supplement where we were talking about advances in neonatal CRRT. And this is one of the sections from there. If you use intermittent peritoneal dialysis versus continuous peritoneal dialysis and tidal, the mechanism is kind of, more than anything else. But I just want to let you know, when you're using the continuous peritoneal dialysis or continuous flow peritoneal dialysis, the advantages are increased solid clearance of a small and larger molecule, higher ultrafiltration, increased time on dialysis, plasma to dialysate concentration, and increased dialysate mixing. Disadvantages are there: inadequate nitrogen balance, hypercatabolic state, and technically more complex and costly. If you use the tidal, only 25 to 50% volume is drained, giving a tidal volume of 50 to 75%. Better clearance of small and middle molecule. As compared to intermittent, it's a rapid clearance of small molecule. It can be done manually in absence of a cycler. So just kind of defining the various forms. PD neonate has a multiple advantage as compared to the MPD, including a decreased need for constant monitoring because of setting of the dialysis delivery, shortened fill rate time. The main disadvantage is its decreased ability to perform at a fill volume less than 60 to 100 ml. The biggest issue is that we deal is actually the very low birth weight baby and extremely low birth weight babies. And they're totally different entity in itself from the neonate. As you can see that the risk factors for them is so different. You have the infection exposure to medications, AKI, including indomethacin, aminoglycoside, antibiotics, and loop diuretics. Then when you're considering the RRT, these very spatial population with very low birth weight and extremely low birth weight baby, limited availability of appropriate size dialysis catheter, limited access to machine approved for use in neonate, and very difficult time with catheter placement. And that's why we have published a paper in pediatric nephrology, clinical pediatric nephrology, about the use of the diuretic, and especially using a bumextide, and we try to convert these oligoanuric or near oligoanuric AKI to non-allegoric by the use of the bumextide, because we do not have much availability of using any kind of KRT in these patients because of the challenges of their size. The biggest challenge we have is actually the patients who are getting complex heart surgery. This is a paper came out as a review article, which is a challenge for us because we do a lot of cardiac surgery, and the pathogenesis of acute kidney injury in the cardiac bypass has a mitigate response of cytokines, increased inflammation, tubular accumulation, renal ischemia, decreased perfusion, and what other dialytic therapy are you going to use? And indications are PD for fluid overload and mild bonded AKI, intermittent hemodialysis against the same, CRRT with critically ill patients, severe AKI, fluid overload, and CBB-HDX, the same indications. And now what we do is, this is a nice systemic review we did, and we looked around. So the best in this patient is that we just put PD catheter as soon as they go for the surgery, the heart repair, and when they come out, they have a PD catheter in place so that you can use that for the fluid overload and mild to moderate AKI down the road if it is necessary. Access is always a challenge. There are certain papers you can see by Harshman describe a successful administration of PD to an 830 grams infant by inserting the dialysis catheter into the left upper quadrant with subsequent direction of catheter to pelvis. Then there was a Stojanovi article which described the improvised use of IV cannulas and umbilical venous catheter for peritoneal access. In US, we're a little bit stuck because of these kind of heroic maneuver and this kind of intervention we cannot do because we have to go through a PNT. But just to kind of throw in there that these are the nice paper I read about the patients who are extremely low birth weight baby and what to do with them. And because of that, the cycler and APD is very challenging. Contraindication to PD is very important. Diaphragmatic hernia, recent intra-abdominal surgery, intra-abdominal malignancy, and inadequate peritoneal surface area necrotizing enterocolitis. Although it's not a contraindication, but you have to be careful with the patients with pulmonary compromise with ARPKD because it causes the intraperitoneal pressure. This is a nice paper which shows the outcome of extremely low weight and very low birth weight babies on PD with various studies. And you can see the duration of dialysis range from almost 24 hours to went to like almost to 14 weeks. And you can see the birth weight ranges all around and what are the common complications. Survival rate was higher in some studies ranging to almost 67%. And some of them are around 40%. So that gives you a spectrum about the renal replacement therapy. And then moving on to the pediatric RRT. I put RRT here because now I just want to re-emphasize that RRT is a wrong term. You have to use KRT. And when you are stuck with the inborn error of metabolism who do not respond to dietary and pharmacological management, they require an expeditious dialytic removal of ammonia, then you're stuck for using the hemodialysis or kidney replacement therapy. Who receive surgical correction of congenital heart disease often receive PD early after cardiopulmonary bypass to prevent fluid overload. And I told you our thing is we just put the catheter as soon as they get the surgery and monitor them. The problem is one who develop MODS in ICU with maximum organ dysfunction happening in 72 hours and mortality happening within 7 days are the changes that you need CRRT. You have to grow up with the concept of kidney replacement therapy only for the fluid and electrolyte. You have to think around acidosis. You have to look around the multifactorial AKI cause leading to the lung involvement, keeping the lung a little bit on a drier side, cytokine medication. And those are the things you have to think beyond in the neonatal population. RRT infants, two major considerations when choosing optical therapy is the indication for dialysis and clinical status. The most common indication for dialysis in young kids, infants are primary or secondary cause of AKI, inborn error of metabolism, intoxication, or we are bridging a therapy to transplantation in infant. PD is often a time the initial consideration, and that's what's shown in our survey also. Also, PD may be a modality of choice if long-term dialysis is likely. However, hemodialysis is generally preferred initially in infant with inborn error of metabolism or intoxication because you need a rapid clearance of these toxins and inborn error of metabolism, ammonia, because they have a high rate of regeneration also. So this is a nice curriculum we have wrote in AJKD, the unique consideration of renal replacement therapy, and I highly encourage you, especially the residents and fellow, to read. And these are some kind of dialyzers and what are their surface area, what are their priming volume. This would help you at least when you're looking into the patients for hemo. This is our paper that we have published actually in Seminar in Dialysis, review article with systemic review looking into the hemodialysis in neonate and infant. And this is beautifully done. And what we found out that the most important indications were like hyperammonemia, acute kidney injury toxicity, and the other indications, which was more chronic conditions associated with AKI or CACAD, cystic disease, and nephropathy and metabolic kidney disease, HUS. So it was found out that it is safe in the children's, but you have to be very careful with hemodialysis in the children's and the neonate. You need to know how to prime the blood because you get cytokine storm when the blood comes in contact and you don't prime the dialyzer before, it can cause a lot of hemodynamic compromise in the patient. This is a nice kind of the layout with the prescription. And this is mainly done for ammonia because you need this to be done for inborn metabolism. And make sure you follow the protocol and slowly increase the treatment. Now, treatment duration may be unknown at onset and will be determined by the nephrologist according to the serum ammonia and clinical status. Typically, it goes for 3 to 4 hours. Now, one thing is very important in the newborn when you're using the CRRT in a form of hemo. When discontinuing the treatment, clamp the lines if the circuit was primed with blood. Do not return the blood in the system to the patient. Discard the whole entire setup with the blood in it to avoid acutely increasing child's blood volume. And after hemodialysis treatment is completed, serum ammonia should be less than 100 times 2, followed by serum ammonia level closely observing for the rebound effect. If you see rebound effect, then you need to use a step-down therapy from hemo to CRRT just to kind of clear the endogenous production of ammonia. This is another thing that you have to use in the KRT. And if the patient has ammonia, you have to calculate the clearance of ammonia. And if ammonia level doesn't fall as expected, you need to calculate the recirculation ratio and ammonia clearance. And this is just to keep in your pocket. And if RR is more than 10% and CNIH4 is low, consider repositioning or replacing the dialysis axis, because then you have a problem with the recirculation. And this is another mode, like if you see after the hemo, it comes down and within 2 or 3 days, you can see that ammonia is regenerating, then you can actually transition that from hemo to CBVHD. So then you have a continuous removal, what we call as a step-down approach. Now, novel technology adopted from the hemo in newborn and infants, and the carpe diem was based on a conventional dialyzer, has a setting of three surface area and circuit priming volume very low, 27, 33, 41. Nidus, which is automated miniature pump with a total ECC volume of less than 10 ml and does not require priming, and the machinery repetitively draw between 5 to 12.5 of blood across the high fluxo polysulfone membrane, and blood flow rates varies from 20 to 45. This is again from our paper that we submitted, and it just summarized the priming volume, the surface area, the blood flow area, and the dialysate flow rate. This is amazing to see. You have Equadex, Primaflex, where the priming volume is so less, 59 ml, 33 ml. Carpe diem, it goes on the basis of the surface area, 0.25, 0.15, 0.075. You can see how the volume changes. Nidus is actually the lowest, which is less than 10. And you can see the surface area and blood flow rate can be variable, and dialysate flow rate can be variable, and pre-filter convection clearance in Aqueduct is around 30 ml per minute. And SLED-F, which you guys have more experience in India, and I think Sidarth has a lot of heparin-free actually SLED-F, and very few cases of the neonate less than 10 kilogram in our series when we work together on our combined assessment, and it shows that it works. It can be used without using heparin. Cardiorenal pediatric emergency dialysis machine, which is carpe diem, and this can do both dialysis and hemofiltration, and you can adjust the UF and the blood flow rate. And like the ultrafiltration rate, the dialysis and hemofiltration rate ranges from 2.5 with the smallest dialyzer to 5 ml per minute. Blood flow range from 5 to 50 ml per minute, and I told you that it comes into the different ranges, surface area for adjustment on the patient size, which is really a good. We don't have that in the US. And I was talking to Mignon McCullough, and she's using the carpe diem in South America, and I was amazed how such a decreased priming volume ranging from 27 to 41 ml. And microhemolyze index less than 0.7 of plasma free release per 100 ml of blood pumped. This is again from our paper. There are two studies from carpe diem. One is Lorenzen and Ronco, which are shown, and it's there on your slides just to show what is the efficacy, and it's feasible. This is how the process of the whole, how the carpe diem is developed, because you can see this is Dr. Ronco's platform, how he started thinking about the procedure, cutting down the blood volume. Then he has the whole setup arranged, and finally carpe diem is here in 2013. up and running. FDA in the US is still incorporating, and I don't think we'll get it very soon. I'm looking forward for it, but South America and Europe have it. We do have Aquadex, and this is David Ashkenazi has done a lot of work, and lately we are bringing that system into our neonatology, and I've been involved in the Aquadex, mainly in the committee for the steering, just to see whether this could be our miniature form of dialysis. Getting frustrated, we don't have nidus and carpedium. And you can have the flow rate between 10 to 40, and you can increase in 5 ml per minute as tolerated by the patient. Machine exhibit beneficial control of UF, and ease of setup is like 7 minutes you can use it. This is what we use in aquapheresis for the patients in adult for CHF. And you can use only heparin for the anticoagulation, no countercurrent dialysis, and a maximum rate of ultrafiltration can go up to 500 ml per minute. This is how the machine looks like, and you can see the continuous flow therapy for temporary. It can go up to 8 hours, and extended who require hospitalization. Used in adult and pediatric patient weighing 20 kilogram or more, whose fluid overdose is unresponsive to any medical management. All treatment must be administered by the healthcare. I have to give this disclosure because that's what they have for FDA approval. Disclosure within an outpatient or inpatient clinical setting, under the physician's prescription, both of whom having received training in extracorporeal therapy. So this is another studies from the same paper. We have done the systemic review of all the neonatal, and you can see 3 papers by Chakravarti, by Dr. Menon, and by Ashkenazi, and these studies have shown that the patients can get the clearance. They say it is Aquadex is more or less like a CBVH format, and that is the little bit of controversy exists among the patients, whether it should be a veno-venous filtration or whether it should be any other form of the dialysis. Now, this is another machine that we use, which is known as the nidus. Nidus is being done by Dr. Malcolm Colhard, and I've had a pleasure of him to come and see me. If you guys have any questions, you can always put that in the chat box. So this basically is, he was here 2 years ago in our neonatal AKI conference. Amazing machine. It's a syringe-driven machine that repeatedly withdraws 5 to 12.5 ml of blood from single lumen central venous line, passing through the blood, through the dialyzer filter, returning back to the body. And at 20 ml per minute, the system processes 5 ml of blood every 5 minutes, and its circuit volume is 4.3 ml, therefore never required the blood priming. The nidus system controls the ultrafiltration rate directly and volumetric to provide a very precise level of fluid removal. Can additionally be used for up to 24 hours. And this is how the nidus looked. And it was so nice when he was here in the US. We could actually see the video demonstration of such a small syringe. And again, because of the FDA disclosure, I have to let you know, the machine shows displayed both pressure control pattern and circuit position, accessible via the touch screen designed for 24-hour use. And the built-in features include instant decrease of the blood rate withdrawal in case of poor line, precise operating status, and syringe position. These are the studies which has been shown. There are like studies done by Dr. Malcolm Colhard, where he has shown this is feasible, and he has around like 8 patients that he has shown. The machine draws an aliquot of 5 to 12.5 ml from single lumen central venous line with a blood flow rate of around 20 ml per minute, processing around 5 ml per minute. Now we have HF20 in our US, so we just have got approved by FDA to use it in a neoborn, and we are very excited. There are the 3 studies done by Rodel et al. And Liu et al. And Santiago, and we have filter available which we can put in the Prisma. And this is actually a nice, relatively low circuit volume HF20 set, 60 ml, which obviated the need for blood priming in the majority. However, when blood priming was required, there was no adverse reaction with the polyecrine ethynyl sulfates. It's a base membrane, so be careful. Definitely priming is required. Solute clearance in these small infants was efficient with correction of metabolic acidosis and electrolyte abnormality. An excellent circuit lifespan was observed. Now, the CRRT is something which you have to, it's challenging in severely ill neonate as it requires obtaining adequate central venous access. In addition to ultrafiltration, often can be set in sufficiently small increment to be suitable for neonate. CRRT is tough until we became the device which is available to mitigate the renal physiology and renal need for the neonate. CRRT gets very, very challenging. These are the mode of CVVH where you just have where you have these are the pattern of the CRRT. Use only the blood flow and the transmembrane pressure. You're doing CVVH. When you're doing CVVHD, you use the dialysate against the concentration gradient. And when you use CV, both veno-venous hemofiltration and replacement, it turns out to be CVVHDF. And this is just the comparison. And convection, you can have small and larger molecule move equally. Limit is cut off of the membrane. High UF needs to be utilized. Moving to what we have, this is a paper in Nature about the consensus panel of guideline of management of hyperammonemia in pediatric patients receiving continuous kidney replacement therapy. And this is so pertinent for the patients that you're dealing in a newborn. And this is what the first I initiate CRRT in these patients. And there are like 6 urea enzyme disorder. And infant with hyperammonemia present with lethargy, hypotonia, and tachypnea, ammonia level of more than 150 necessitate further diagnostic evaluation. Worse outcome is associated with persistently elevated ammonia, more than 800 for 24 hours. Prompt treatment is critically rapidly clear. And this is a very important article. I hardly suggest all the neonatologists and the nephrologists taking care, pediatric nephrologists taking care of these kids. This is a guideline-based presentation, and ammonia is very toxic to the brain. And this is what has shown what are the early symptoms. You will have hepatomegaly, decreased urea production, increased hepatic enzymes. You will see the gastrointestinal manifestations. So keep that in mind. And apart from that, then we moved up and we defined actually the RRT, and RRT should be employed for diffusive and convective mechanism and in hemodynamically unstable volume overloaded patient. While hyperammonia infants are not volume overloaded, we speculate the CRRT could be preferred. High risk of hemodynamic instability from underlying metabolic disorder, small patient size, and use of drug that increase nitric oxide release like arginine and low systemic pressure. This is how the mechanism in the hyperammonia in the newborn is peritoneal. You do diffusion plus ultrafiltration. If you do hemo, you do diffusion. If you do continuous hemofiltration, ultrafiltration, continuous hemodiafiltration, diffusion, and ultrafiltration. See the efficacy of a small molecule and tolerance. Hemodialysis is poor. CRRT is more tolerable. This is another nice way of looking into this guideline where we have speculated if you do hemo, CVVH, and CAVVHD with this blood flow and dialysate flow, how much would be your clearance of ammonia per ml per minute per kilogram body, and how much you can have a filtration fraction. And that will help you to determine the prescriptions in these patients. What to do next? Prepare a hemodialyster, give them some sodium benzoate and sodium PPA, and begin hemodiafiltration, if not decrease in the ammonia. This is, and you do PD is the only available modality. Then the consensus panel that we decided that you should use in the patients with the rapidly deteriorating neurological status of coma, cerebral edema, high level of ammonia more than 400, rapid rise in ammonia more than 300, you go for PD. Hemo is necessary for hyperammonia patient with a rapidly deteriorating neurological status of coma or cerebral edema. Hemodialysis or high-dose CRRT, which I'll come to that's another advancement, maybe be initial therapy for patients with ammonia level greater than 1,000 units per mole. Recommendation from the CRRT is high-dose CRRT with blood flow of 30 to 50 ml, aiming at QB to QD ratio more than 1 point may be used for initial therapy of patients with blood ammonia level more than 1,000 millimoles per liter. Step-down CRRT can follow hemodialysis or high-dose CRRT when the ammonia level is less than 200 on at least 2 hourly measurement, keeping in mind that the therapy with nitrogen scavenging agent may be sufficient to prevent the rebound. These are the modality, and this is nice review. We did look into the various modality and the response. And you can see the improvement on hemo or in continuous CVVH and CVVHD is around 50 to 62%, and it's 18% on the PD because it's a rapid clearance of the ammonia. High dose CRRT is and you have to understand this is done for the inborn error of metabolism in a neonate. You need to have a clearance. Dialysis flow rate will be total at least 8,000 ml per 1.7 meter square, and high dose CRRT once. And this is what we proposed in our COVID-19 AKI PCRRT guidelines published just 1 month ago. What we were saying is if you have a lot of interleukins and a lot of chemokine response to a high dose CRRT 12 hour low, you'll have more middle molecule clearance. But this time you have to be very careful with the high dose CRRT. It's fascinating to do. I did it. It needs a lot of support. Technically, you have to stay there when you're doing high dose CRRT because the phosphorus, sodium, potassium, it goes very quickly. And sometimes you don't have to use anticoagulation in a high dose. You can always use some pre-filtered replacement fluid to make it coagulation gets a little bit better. And so this is another new concept of the CRRT. And then you do a step down approach when the level is less than 200, increase the clearance to almost 250 meter, 1.73 meters square an hour. Huge difference what you're doing in high CRRT. You have to be very careful with the ECMO, and we have seen the connection with an VV ECMO which came out, and this is our paper, position paper, where we use CRRT machine. I will not recommend you guys to use just the filter with the ECMO machine to code the clearance because that's just scuff. But I will highly recommend you to have a VV ECMO attached to the CRRT machine with the replacement. And this in this paper, you can see kidney replacement therapy that came out. It really explains you the connections. And definitely one thing is very important when you have these modality, what are your layout, what are your ICU setup, what are your critical care is satisfied, what do they feel comfortable to manage this, how are the nurses going to take this, how are they well trained. So whatever works in your unit, use it. Don't go for these fancy things until you are comfortable, intensivists is comfortable, dialysis nurses are comfortable, and PICU nurses are comfortable. So what's going on with this new KRT advances? The development of pediatric dedicated KRT devices has been a huge step forward in the treatment of AKI in infants, and I'm in some of the committee. Pending positive trials, these systems may become mainstay of AKI in infant and small pediatric patient. However, with any extracorporeal circuit, they do have their drawbacks, and use of extracorporeal blood purification method has been associated with activation of inflammatory pathway and consequent cytokine storm. Also need what we call the term hemo incompatibility, and that you have to take into account. Therefore, the next challenge may involve improving the current system to prevent such inflammation occurring. This may include the use of development of less bioreactive materials, suppressions of the blood-air interface in the extracorporeal machine, in addition to hemoincompatibility. Initiation of KRT is associated with hemodynamic changes that may lead to cardiac stress via hypovolemia, while sensors to the measured blood volume tool to monitor hemodynamic status have been proposed. Neither of this alone has shown significantly improved the cardiac stress related to the KRT. As such, the development of devices that may combine multiple tools and the use of advanced analytics to identify and treat such changes may be in the horizon. But at least in US, I'm excited. I have HF20. I do not have CARP-DM. I do not have the NIDUS to use, and we'll see how the things will evolve. We have done high flow CRRT, and CRRT works good for the infants, and we use the CVV HDF, and PDs are also growing, but I think you are more leaders in PD as compared to us, and I think PD is still any modality what you have, you act prompt will have. With that, I end my presentation. I give it to Dr. Ganesan. If you have any questions, please let me know.
Thank you, sir. Thank you for introducing us the new terminologies in dialysis, and it was an enlightening talk. We have few questions to take. In neonatal acute manual PD, sometimes the body weight is increasing every day despite of adequate solute clearance. Why is that happening? How to deal with?
Oh, come to my club of frustration. And that's what I hear from neonatologists. They are not, I think they just, the fluid sometimes goes into the gutters and we don't drain it well. There is an issue with the inadequate drainage because of the peritoneal membrane. And secondly,
Clearance.
the size of the catheter, which is so an issue, like, and the curling of the catheter. They don't even have pelvis where you can curl the catheter. So yes, that happens a lot. What I will do is I'll do a little bit of rapid exchanges and try to flush the catheter. Tidal, I have not done in neonate, which is another approach to do, but tidal will put you more at the risk for having the weight gain as compared to the regular. So I do very conventional PD in that case, just do some rapid exchanges. Welcome to my world. I see that all the time. The electrolytes getting better, patient is getting better, the weight is going to increase. I'm sure the peritoneal membrane is not ready. Those pore model, what we talk about in children's, I don't think in a neonate it's very well defined about the pore size. So yes, this is immaturity of the peritoneal membrane, ineffective surface area, inadequate drainage, and the challenges with the catheters that we have would be a limiting factor or drawback for these kind of problems.
Thank you, sir. And the next question is, whenever the baby is on peritoneal dialysis, we lose a lot of albumin and the child becomes edematous too. Is there anything can be done to cut short that?
So they lose a huge protein. It's just not the albumin. They just lose the amino acids. They use a huge protein loss. So sometimes what we can do is what I have done, and this I learned from Tim Bunchman and McDonald McCullough. McDonald McCullough is the guru of the PD, and Kim, yeah, those are like my to go if I get stuck. Is you always put the patient on some kind of a TPN, on some kind of a PED. I will not recommend you to give you an albumin infusions in the neonate. That's not a good way of doing it because it's not physiological. Secondly, the hospital will have a lot of challenges getting it, but any kind of TPN, and again, that changes the concept of renal support from renal replacement therapy can help. But definitely protein loss is there. It's just not the albumin, essential amino acid, and I don't know what else you're losing. Electrolyte disbalance, hypokalemia, they get hyponatremic. Those are the part, again, going back to I answered, but if you can put that to any kind of feeding pattern with the TPN, you can always maneuver that. And I do that a lot. I always prefer them to have a TPN with my PT, and I just maneuver the electrolytes and everything to the TPN versus doing peripheral IV albumin infusion and all. I will not recommend you just to replace albumin, which some of the people in some country they do. I would rather just play around with the TPN.
Okay, great, sir. And so what is the minimum weight for usage of CRRT with the HF20 filter? What's your
Less than 10.
experience on that?
So I've not done yet. We just got approved. I was in the FDA steering committee recommendations, and it just got approved. We got the filter. I will be very inclined towards even using less than 10 kilogram. I'll be very careful using in very low birth weight baby and extremely low birth weight baby. Let me start. I will let you know. But you guys have HF20, right, in India?
Yeah, we had been
Siddharth?
using it. The minimum weight which I have used is 3.5 kgs, not lesser than that. So I just
Right.
wanted to
You are more courageous than me. I'll start with at least 7 to 8 or less, around 5 kilograms to see. But Siddharth used to tease me all the time when I come to Medanta that he used HF20. Tim and I get very frustrated. So no, I will not go less than 3.5 or 4. But I cannot give you my experience until as I use it. We just got the filter and we'll try. But I have gone down to almost 4 kilograms, 4.5 regular convention CRRT. It's a challenge. It's a challenge. So different. When I do adult, I put the person on CRRT and I forget, and he feeds, I sit there for the whole day for CRRT. Such a huge challenge. But yes, there is no such recommendation, but it's a huge issue with the blood flow and the clearance because you're doing convection, diffusion, and filtration. So be careful with the electrolytes in these young infants. CVBHTF is more challenge for the physiology of the baby as compared to the PD or as compared to hemo because you are using 3 modality with a middle molecule clearance, and God knows what else you're removing out in these newborn. Newborns are so different as compared to the
Okay.
children's.
And so the next question is, when do you decide to stop peritoneal dialysis in a neonate with AKI?
When they have good urine output, electrolyte stability, I just don't stop abruptly. I just flush the catheter, leave it there for a day and see how the things evolved. But most of the time, when you reach your goal of good urine output, electrolyte balance, nutritional balance, respiratory status, if those things are evolving and you see those things moving in the right direction, then you give a halt to the PD. You never stop it. You just take the exchanges, or you can cut down the exchanges and see how the things evolve, and then slowly you just leave the catheter in plate and flush, see how the patients go. And whenever I have done that, I always burn my hand. I have to go back and restart because something happens in between. Cardiac patients, you have to do it for the fluid. For cardiac patient, I will say that monitor the fluid rather than looking into the electrolytes and urine output, because the fluid is a big issue, and nutrition. These are the two things on a congenital heart disease patients when they come with the PD that you have to monitor: the growth, the fluid, and if they have a Fontaine procedure, they have a ventricular septal defect, the cardiohemodynamics, you need to talk to the cardiologist and cardiothoracic surgeon. So that is a total different scenario as compared to the AKI of bread and butter variety. So there are three distinct parameters. Number one is the cardiovascular patient. You need a comprehensive cardiovascular hemodynamics, fluid overload. You have to make sure the nutrition and growth is there, because these patients are very hypercatabolic. They are on oxygen dependent and respiratory status. So that's one entity. When you're talking about the inborn error of metabolism and you are doing PD catheter, serum ammonia level with less rebound is a good, and neurological status is a good parameter for you to halt on the PD. When you're talking about the AKI, this is due to the ischemic ATN because of the low Apgar score, because of chorioamnitis. Then you're looking for a general indications like good urine output, electrolyte balance, good nutrition, and respiratory status, and then halt it and see and readdress again. So it cannot be a general parameters. It's just a distinct entity for each and every subset of these patients.
Okay. And so the next question is, can we start feeding during peritoneal dialysis?
Yes, please. Go ahead. You're talking about the enteral feeding, or you're talking about the IV TPNs?
Enteral feed. Enteral feeds.
You can do the small feed. You can do the small feeds. I know neonatology will give you a hard time about it because they think that there is a gaseous bloating or anything. Sometimes what you have to be careful is cut down your volume in the exchanges and give a little bit of belly a rest if you feel like that the belly is getting gaseous distension is there. I'm a big proponent of internal feeding right away.
Okay. And the next question is,
it should be a small trophic feed.
Small feeds, trophic feeds. Okay. Yeah. Look for how the baby is tolerating and then increase the feeds. Right. What is the neonatal catheter you would like to use for CRRT?
Oh my God, you're talking in US or you're talking in India? The smallest possible you can, and there is no answer for it. And I'll take this answer from Tim Bunchman. The size doesn't matter, the placement doesn't matter. I need a good blood flow, I need a good clearance, no transposition, and less abutting of the catheter to the venous wall. So whatever the accessibility you have, make sure it goes into the right ventricle of the heart. You can have a good flow. It is completely going down to almost 1/3, so you will have a good flow output. Whatever you prefer, whatever you have your institution. Again, it's a good blood flow, integrity of the axis, no much abutting against the wall, and no negative pressures, because your machine will alarm and your life will be a hell. It'll be alarming every second because how the prisma is done, it alarms on the basis of the venous pressure. So anything what you have is good. You just have to look into the physiological parameters for the catheter.
Okay. In India, we use 6.5 and 7 size catheters.
That's fine. 6.5 is actually very good.
And 7 size. And we have to look really, as you said, we have to really look for the blood flow. If the blood flow is good, any size catheter would be fine with it.
You have to be very careful with the blood flow when you're dealing with the inborn error of metabolism. and especially with a high BUN, because sometimes, and that's a problem, is when you do the CRRT, you immediately jump. I will go slow escalated dose, because if you clear these patients very quickly, they do not have iodogenic osmosis in the brain, so they have a lot of issues, neurological and the intracranial pressure. Yes, any blood flow, 6.5 works, 7 works too. And also depends who's putting the catheter. We have surgeons, pediatric surgeons, who put the catheter on these patients, and they are very well versed in our setting.
Fine. Like, and the next question is, from which serum creatinine figure should you have dialysis in a newborn if his mother had eclampsia?
So again, that's what I showed you in my paper, renal replacement to renal support. It's just not the creatinine. It's just not the creatinine. You have to look into the patient itself. If you are dialyzing somebody just for solute and creatinine, no, that's not the concept you have. Renal support entails fluid overload, mode of injury. With preeclampsia, you have issues with the hemodynamic stability and typical ATM that you deal with the patient. Fluid and electrolytes, fluid I've already talked about, electrolytes, urine output, and using the Akin classification, taking into account the rise and the trend of the creatine rise, fluid overload, how the urine output, put all in perspective. Please do not treat the numbers. Do not treat, just see the trend of the rise within 12 hours, 24 hours. That tells you more, because serum creatine doesn't tell anything for the neonate, because they do not, this is not their endogenous creatine production, because they do not have much muscle mass. It could be a misnomer for you with the moms, and generally around 72 hours you see that they have cleared. But again, if they are born with a neonatal AKI, it's very hard for them to clean their own creatine, what is the reflection of their mother's serum creatine. So it's a very tough situation. But if you are dealing the numbers and you want that trigger number for starting the dialysis on the neonate, so answer is no, and you will never get an answer what the right number will be with the preeclampsia patient.
That's right. And what is the conventional PD fluid do you prefer, the concentration of glucose you prefer for acute kidney injury, for acute dialysis?
Any routine what you use for chronic, we never change it. We are not allowed to change any PD. We already have a pre-formed PD fluid, so we cannot change whatever we get. What you use for chronic, you use for the same, for the acute. There is no difference.
Okay.
And sorry, go ahead, Dr. Ganesan.
I'm sorry, like as already discussed, like you said, like for you would just leave the catheter, PD catheter inside, and you just flush the catheter and wait if the urine output is good or the baby's creatinine is dropping. In that case, are you using the acute PD catheters or it's a chronic PD catheters?
So we generally do the chronic, acute and chronic, it's kind of the same. I will say for acute also, you have to hold it. You just cannot take it out. Just hold it for 24 to 36 hours to see how you are with the patient scenario. Because once it is out and you need another, there is no abdominal muscle valve or musculature to hold that catheter.
Okay. And so, like, I have my own personal question. We had a neonate who's around 37 weeks plus of gestational age and had a HIE. And following that, the creat was initial, the day 3 documented to have 3.51 plus, and urea was around 150. So we landed up doing acute peritoneal dialysis. But the child was anuric at that time, and slowly on day 3, the child had a good urine output, but the creat was just holding. It did not drop much. Then in PD, during the PD course of 3 days, it just fluctuated between 3.5, 2.5, 2.8, but it did not drop as we expected. And the urea also was standstill. So we just thought we'll remove the catheter because urine output was very good. We landed up removing the catheter and we started the baby on feeds. The creat has started dropping, but the urea started creeping up despite giving a very good feeds. So what is your take on that?
Tubular immaturity. What you are considering urine output, did you check the urine electrolytes?
Urine electrolytes, we had checked. Sodium was, say, around 70 or something, and potassium.
So he was coming out to almost like, so a lot of this was also saline dialysis too, because technically you should be peeing around like 30 to 35 milliequivalent. So this is a tubular immaturity, and the urea transport is not very well developed in the kids to clear your, but there is some source where you have endogenous production of urea in the patient. Where is this urea coming from? Because this could not be maternal. It still, I will say, the solute reflects the endogenous function of the kidney was not very good. You took out the catheter, which is fine on the basis of the urine output, but I'll be very careful with the urea of at 150, 114 and neonate to, I definitely want it to a level around 70. I should have done more rapid exchange because of the change in the mental status and intracranial pressure. So again, those numbers doesn't reflect the endogenous clearance via the urine output, and that also reflects the tubular immaturity. I would have gone a little bit more aggressive dialysis. Maybe I have not done a lot of UF or gone down the concentration of the sugar in the rapid exchange, but I would definitely bring urea down because there is some endogenous source for the catabolism, and I don't want to leave the patient on the create of the urea of 150. I don't leave adults with a urea of 150 because the new data in AKI literature has come, you have to be less than 70. So you have to be careful. And here I will say in this setting, you should be focusing the numbers because urea of 150 is very concerning for a newborn who does not have any resource for generating it unless there is some endogenous overproduction or hypercatabolic state. So I would have not taken the catheter route. I would have a little bit dialyzed it 1 or 2 days extra, not take out a lot of UF because you want the kidneys to repair, but at least bring it to 100 to the level that you want. Creatine doesn't tell me anything in a newborn. You know that. Urea is a more marker.
Okay, I had a little doubt because like I have started on enteral feeds, probably the protein load in the feeds would have changed the urea because create has started a little bit of drop, but the urea started creeping up. But now it's static. It just stays in 80s, 90s.
I would have brought that to the level of 80 and 90 before taking out the dialysis and then put him on the enteral feed because you don't want to, urea is very bad. It's kind of isosmotic. It goes in intracellular and extracellular space more quickly. And you have to take into account urea is just one of the tip of the iceberg. There are many other markers and other various kidney failure toxins that could accommodate. So either way is fine, but I would definitely bring the level down. I will not be very enthusiastic to stop. And that's what my challenge is always when I go around. Like, no, I don't. I want to continue for 2 or 3 days for electrolytes, for fluid overload. I need to make the UF to get better. So it's a challenge, but I will definitely bring the numbers down as compared to the taking out more prematurely. And that's my perception.
Thank you so much, sir. I think we are done with the questions as well. It was an enlightening session. We really enjoyed your talk, and you really made up the day because like Dr. Sidarth was also away for an emergency. Thank you so much. Thanks a lot.
Thank you. Thank you. Thanks a lot. Thank you. Bye-bye.
Thank you so much, sir. Thank you. Take care, sir. Bye-bye.